Dr. Karthikeyan is a good friend. He's an intervention cardiologist, and he is at SIMS Hospital at Vadapalani, Chennai, where he is a very renowned speaker in the Association of Physicians of India and Chennai Cardiology Club. And with these few words, I request Dr. Karthikeyan to proceed with his presentation, sir.
Thank you, Dr. Prabhu, and congratulations on the new post. And coming to the role of CT coronary angiogram in subclinical atherosclerosis, when I was preparing this lecture, I suddenly realized for many years now, calcium score and CTA have proved their worth in picking up the lesion and characterization of the lesion, but very little has been studied. Although few people have studied, but very little has come out in terms of what happens to the cardiac structure and function when there is clinical atherosclerosis. It is a good place to start when you are picking up minimal plaques or mild disease. It is a good practice, I think, in the future with the advent of good CTs, MRI and echo, to always have a look at the cardiac function also in terms of the quantification of the strain, the stress pattern, the myocardial swirling, which we can see in the new generation 4D MRIs. As far as the definition goes, subclinical atherosclerosis is characterized by the presence of asymptomatic, non-obstructive, or obstructive but asymptomatic atherosclerosis. Most of the time, clinical obstructive atherosclerosis develops when the area encroaches about more than 50% of the vessel lumen or when ischemic symptoms set in. What most of us are bothered is the clinical non-obstructive atherosclerosis, which is less than 50%, but which has vulnerable plaque morphology or a lipid plaque with a very friable base, which will rupture and cause acute coronary syndrome. The subclinical atherosclerosis, I think, is a physiological process, and generally in normal individuals who are not otherwise hereditarily predisposed, usually starts around the second or third decade. So starting as an anatomical imaging tool, we have progressed to morphology, and now we are looking at biological metrics as far as CT coronary angiogram is concerned. And I will highlight some of the important things where we are started to look at physiology rather than our preoccupation with the stenotic disease. So essentially what we are doing now is, as all of us know, we have become extremely good in picking up the lesion, characterizing the lesion, quantification of the lesion. But in my mind, the future is picking up the physiology when there is no stenosis. If we can predict whether this person is going to develop significant event, even when there is no stenosis at an earlier age. In a patient who has minimal, mild to moderate disease, is he at a risk of cardiac failure because of the chronic long-standing subclinical atherosclerosis, whether it is going to have any effect on the flow. We have become extremely good with plaque composition and high-risk plaque features. I'll just highlight the high-risk plaque features. Most of the high-risk plaques or the so-called vulnerable plaques are low in attenuation, that is less than 30 Hounsfield units. They do have a spotty calcification, which makes the matrix very friable, and the base of the vessel is remodeled and it becomes wide. So the constellation of positive remodeling, spotty calcification, and low attenuation plaque, which has been now very famously called as the NRS sign or the napkin ring sign, is the one which we have to look for, even in the presence of a non-obstructive lesion. At the end of the day, the idea is to pick up the lesions and modulate or start the treatment when there is positive remodeling like it's seen here. And we do not wait till the patient goes on to develop a vulnerable high-risk plaque which has ruptured and caused stenosis. One of the interesting things which we have been doing, even though we don't have any specialized software, a simple look at the pericoronary attenuation, which is called as the PAT, perivascular attenuation of CT. Maybe in my own clinical practice for the last 1 year, I've been doing maybe 5 or 6 patients who come for a routine CT angiogram who have non-specific symptoms. We start looking at the perivascular fat, even in the calcium score. And many times, if the vessel is ectatic and it has a spotty calcium, and if the simple attenuation of the fat outside the vessel showing a reduced value, that is, normal fat will be anywhere between -200, -300. So when you measure it in different areas and you find the fat attenuation around a suspicious vessel is increased, we have found a good correlation between significant plaque being present and or a stenotic lesion being present. So this is something which is new. which is very simple. Even if you don't have a fancy software like this, a simple Hounsfield unit measurement can do. And probably that is the closest what we come across to the endothelial dysfunction, which for time immemorial has been thought to be the earliest marker of a vulnerable patient or a vulnerable vessel. Now, coming to the coronary artery calcification or the CAC score, which has been extensively studied, and they represent the mineralized atherosclerotic plaque and has been consistently demonstrated to represent the total atherosclerotic plaque burden. So many studies have shown higher the calcium score, the associated surrogate markers like LA volume index were increased in many of these patients, even if they are asymptomatic. And probably if they are assessed further, we will know that probably they are in the early stages of diastolic dysfunction. Now, one of the very often quoted study, the MIFA study, looked at coronary artery calcification and myocardial perfusion in asymptomatic patients. And the observation was the coronary vasodilatory response was associated inversely with the presence and severity of a calcium score. So the more calcium score, even in an asymptomatic adults, the percentage of patients having abnormal vasodilatory response was found to be high, and probably it can be taken as the reason can be taken as significant subclinical atherosclerosis. Now, what happens to the patients where calcium score is 0, but they are symptomatic? So whenever the patient calcium score is 0, previously we all used to think, many centers went to the extent of declaring or giving a warranty certificate telling your calcium score is 0, you are safe. But then we know, especially in population like ours, the presence of a non-calcific plaque burden is very high. And the likelihood of obstructive coronary artery disease being present even in the absence of calcium score 0 is very high, especially in diabetic population and patients who are ethnically predisposed to atherosclerosis. One another important role of CTA is in the guidance of medical therapy. As all of us know, the final goal of all these investigations is to prevent sudden cardiac death or myocardial infarction, and or to decide whether there is a need for revascularization. So successful prevention will always be based upon accurate identification and classification of therapy. And in that setting, calcium scores and CCTA have come a long way in helping us understand the prognosis and to modify our treatment protocols. And to that intent, a lot of these studies were based on diabetic patient population, and it is well known that long-standing diabetes has a direct anatomical imaging correlation with the presence of subclinical, significant or non-significant atherosclerotic process. A few words about plaque characterization, which tells us what kind of management a particular patient will have to undergo based on the CT morphology. Initially, we used to go by the presence of the Hounsfield units and characterize them as calcific plaques, low attenuation plaques, mixed plaques. And as all of us know, calcific plaques and spotty mixed plaques carry more risk of acute MI or ACS, and the presence of stable calcified plaques are more seen in patients such as long-standing diabetics who come to us with angina. Over a period of time, we realized it is not only the plaque morphology and the plaque characterization, but also the quantity of the plaque burden. Patients with low attenuation plaque burden, which was very high, roughly around more than 5 to 10% of the total plaque burden, they were found to have higher incidence of acute coronary syndrome. And what we try to identify when we are subgrouping or looking for the volume of the lipid-rich plaques is the location of the plaque, the extent of the plaque, the length of the plaque, and the Hounsfield unit of 30 or less. So this is one clinical example where we have done a curved planar reformat showing mild to moderate disease of the entire right coronary artery. So when you measure the low attenuation plaque burden, more than 70% of this vessel has a non-stenotic low attenuation plaque with a vulnerable morphology. So this patient, even in the absence of a clinical symptom, will fall under the category of vulnerable vessel with a vulnerable plaque. So again, an example of a non-stenotic lesion with a spotty calcium, which is seen. Now coming to the concept of coronary remodeling. As all of us know, early in the phase of atherosclerosis, the coronaries undergo positive remodeling to accommodate the enlarging plaque. So any plaque which occupies more than 40% of the region with a large necrotic core, which means a low attenuation. So this again is vulnerable plaque with showing you the plaque rupture, and again a patient which highlights the progression of a coronary vulnerable vessel to a plaque rupture. I've shown the morphology here. At July, this patient came to us with non-specific chest pain, has an ectatic vessel with a long segment of vulnerable plaques. In September, he presents again with a typical chest pain with raised troponin levels. He wanted to undergo a CT angio again, and we see the plaque rupture with the stenosis which has happened in the same patient. So this patient taught us the concept of vulnerable vessel, the asymptomatic atherosclerotic cascade, which ends in an acute MI. Again, another example, ruptured plaque with the anterior wall MI. Unfortunately, this patient landed to us with an apical clot and a SMB thrombus. We have found the coronary CT angiogram very useful in the follow-up of patients with HIV. As all of us know, HIV patients have an accelerated atherosclerosis, and like diabetic patients, these patients on follow has helped us understand the process of asymptomatic atherosclerosis very well. So today we not only mapped the coronary atherosclerotic process, but also with the help of the new generation drugs, we are able to manage these patients well. Thank you. So it is structure versus function with flow now.
Thank you, Dr. Karthikeyan, for that nice presentation.